Everybody who is just shuffling in, and thank you for joining us for today's webinar. We are getting a lot of folks who are making their way into the Zoom room right now. So I'm just going to give a few minutes or like a minute just for everyone to kind of get settled in, get their audio connected, and get linked up, and then we'll go ahead and get started. Great. And we're getting a couple more folks. So folks, I'm just going to give another 10 seconds or so, and then we'll get started with the webinar. All right, I think we're doing pretty good. So we'll go ahead and get started. So good afternoon, everyone. It is October 29th, 2021, and you've joined us for today's webinar, Driving Integrated Health at Your Organization. We'll be talking about quality improvement and foundational factors that lead to success. Next slide, please. I am Andrew Phillip, your moderator for today. I am the clinical lead and senior director for partnerships at the Primary Care Development Corporation and a national integrated care nerd. Next slide, please. And if this is your first time joining us and you're new to Primary Care Development Corporation or PCDC, we are a national nonprofit wholly founded with the mission of addressing health equity through enhancing and catalyzing excellence in primary care, including behavioral health. We do this through three kind of key avenues. One, through capital investment as a community development financial institution, where we have invested over $1.3 billion since the early 90s to enhance primary care. Through training and technical assistance like today's discussion, where we offer consultation and support around nearly every topic related to primary care, from integrated care to operations, billing, coding, and more. And also through advocacy and research to really maintain the support that's needed to bolster safety net services all over the country. Next slide, please. So this is just a brief disclaimer here. The views that will be shared with you today on our webinar do not necessarily reflect those of the federal government, including the Substance Abuse and Mental Health Services Administration, or SAMHSA, Health and Human Services, HHS, or any other federal entity for that matter. Next slide, please. Okay, so today's a really important and pretty exciting day for us here. It marks the kickoff of actually our third annual series in partnership with the SAMHSA Center of Excellence for Integrated Health Solutions, the National sort of Training Center for Integrated Care. Our work with the center is focused on really highlighting the value of integrating primary and behavioral health services for a more robust, really more patient-centered, value-driven method of services delivery. So last year, we covered sleep health and integrated care, which is, the series is actually archived for your convenience at pcdc.org/sleep. And the year before that, we covered diabetes and integrated care, which you can find also at pcdc.org/diabetes. As this is our third series, we're actually zooming out a bit now and sort of thinking back about sort of, again, briefly revisiting what are the sort of foundational elements of integrated care. There's a lot of different models, but also we're going to be diving deep on things like quality improvement methodologies, on partnering, understanding that integrated care usually takes a bit of a village. So how do we build really valuable relationships to provide integrated services? And then later this year, or in 2022, we'll be getting into screenings from, let's say, if you are a behavioral health entity or primary care, rather, bringing in behavioral health services, what are the considerations there? If you are coming from the behavioral health domain and you are trying to bring in primary care services or even primary care screenings, what do you need to consider there? So we'll be tackling these different questions throughout this year, and we invite you to join us for the ride. And you can stay tuned at pcdc.org/invite integration. So it follows a theme. So we'll move on to the next slide here. I want to briefly introduce our presenters today, although I'm just going to briefly cover them and invite you to learn more. So our first presenter today is Amy Breyer, a licensed clinical social worker and senior program manager here at PCDC, joined by Deborah Johnson Ingram, senior director and the lead of our patient-centered medical home and compliance initiatives, and Maya Morris, who brings expertise in community health, operations, workflow, and a whole lot more. You can learn a lot more about Amy, Maya, and Deborah at, you guessed it, pcdc.org/staff. All right, next slide, please. So one last thing before I turn it over to our team, we have some polling questions for you. On the first item that you see coming up on your screen here, we'd like to know what your setting is. And really, this is sort of for the most part, right? Are you kind of mostly in a traditional primary care setting? Are you mostly in a behavioral health setting? Are you in a fully integrated setting? We'll talk more about that later. What kind of role best defines your work? Are you a physician, a nurse, nurse practitioner, a social worker, case manager, care coordinator? For all of these, if you're in like an other category, you've got the chat. And I see actually a number of folks have already started using our chat. Pop in the chat there. What do you do? Where are you calling in from? Tell us a bit more about your work so we can get a sense of who we're speaking to. And then the last item that you're seeing on the poll here, we're going to do this at the beginning and also the end of the session. It's important to us to get a sense of what the value of these sessions are and what you're learning. So you'll see this question again at the end, but you can go ahead and answer all three. And then in aggregate, not showing any one particular answer, we're going to share some of your general trends and responses. So we'll just give just a few more seconds for folks to make your selections there. And great, we're seeing a lot of activity in the chat here. We've got folks from state payers, very nice. PIPIC grantee project director. Oh yes, these are integrated care grantees through SAMHSA. Very nice to see. Population health pediatric psychologist, occupational therapist, director of clinical service lines. Interesting. LMFT, very nice. Student pharmacist, excellent. So as we see here, we've got a really nice blend of folks who are in really all sorts of different settings, whether it's on the primary care side, but very heavy behavioral health presence. And I think this keeps going up every year, but more and more folks are sort of squarely in this integrated care domain, which is really nice to see. We've got also like a really nice blend of professionals with a pretty even spread between therapists, social workers, care managers. We've got QI folks, which I think you're going to be pleased with today's session, and a lot of others. And so again, just really nice. We've got peer wellness coaches, nurses, behavioral health consultants, vice president of clinical operations, CCBHC is great. Glad to have you. I'm going to stop reading this off, but there's a just great representation here. We've got a great audience today. So with that, we can move ahead into the next slide, and I'm going to turn it over to Amy to really take us through the content for the next part of our discussion here.
Great. Thank you so much, Andrew. Welcome, everyone. We're going to set the stage for our conversation today. Next slide, please. So for today's key objectives, we're going to identify characteristics of integrated healthcare within organizations. At the end of today, we'll also be able to explore the differences between the quality improvement agenda for behavioral health and primary care. We'll describe how diversity, equity, and inclusion, DEI, intersects with integrated healthcare. And lastly, consider communication variations based on the type of service integration. So next slide. So a little bit about why this matters, some background, some content to sort of set the stage. Next slide. So I want to talk a little bit about integrated level setting. What are your peer organizations doing? What do they look like? Are they federally qualified health centers or FQHCs? Are they CCBHCs or certified community behavioral health centers? Are you a specifically diagnostic and treatment center, a community health center, a substance use treatment program? And do you have co-located or is some kind of combination of the above? And what does success look like along the integration spectrum, right? We know that it's going to look different and success will be defined differently based on the facility that you're in, whether you be at a hospital, an outpatient clinic, whether you're a behavioral health provider or you're at a small practice of where there's primary care services being provided. And we want you to think about how do you leverage your expertise in other areas within an integration framework. What's your role? How do you perform quality improvement activities? What are you doing as far as care team functionality? What roles of the staff who are involved in your practice? What do they play, and how do you leverage the expertise within those different domains? Next slide, please. So I'd like to start us off with a quick definition of what is behavioral health integration. And here we're defining it as the care a patient experiences as a result of a team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. However, integrating care is not a response to poorly functioning behavioral health. Integrating care is also not a response to poorly functioning primary care. Integrated care is a mechanism to support population-based services to intervene early, improve physical and behavioral health, to right-size resources and improve access, as well as to limit, say, premature death, suffering, and stress. Next slide. So I want to review the spectrum of integration. So we don't live in just one area. It's on a continuum. We're going from a more coordinated care or off-site care where there's minimal collaboration. Patients are referred to a provider at another practice, and providers have minimal communication. Or there's some basic collaboration going on where providers at separate sites periodically communicate about shared patients. This is where you have some screenings, navigators, there's care and case managers communicating. And then we're moving along this the spectrum of integration to co-located care. This is where we have basic collaboration where providers share the same facility, but they maintain separate cultures and develop separate treatment plans for patients. This is also where we get closer collaboration, providers sharing records and some system integration. This is where we start to see some health homes and that level of integrated care happening. And then finally, where we are here at the far right, integrated care. We're looking at closer collaborations, yet still providers developing and implementing collaborative treatment planning for shared patients, but not necessarily for other patients. And we're looking at full collaboration where providers develop and implement collaborative treatment planning for all patients. So that's really the ideal of where we want to be with our spectrum of integration as system level integration. Next slide, please. So at this point, I'd like to ask a poll. What type of integrated healthcare setting is your organization? You gave us a lot of information in that first poll. I'd like to double down and find out a little bit more about your settings besides just integrated. If you could, please quickly put in your responses for coordinated, co-located, highly integrated, or none of the above. That would be great. Thank you. And I think we'll give you just 30 seconds to do this one. It's pretty quick, you know where you are. And we'll talk a little bit more as we go along. Do we have the completed results? Great. So it looks like 44% of you are at the coordinated stage of integrated healthcare setting, which is wonderful. 21% being at co-located, and then 23% being highly integrated. 12% of you are none of the above. I'm curious if you could put into the chat the none of the above. What does that represent for you as far as your settings? That would be helpful. We can take a look later on. I'll look at it and maybe we can have some discussion as we go through the rest of our presentation today. Next slide, please. Great. So I want to continue along with the integration continuum. And this was developed by Montefiore Care Management Organization, the New York Community Trust, and the National Council of Mental Wellbeing. There are 8 domains that are identified here. We're looking at the first one. And you notice on the left that it's broken down by key domain for integrated care that's evidence-based and recommended. The first one being screening, referral to care, and follow-up. And as you can see, as you go to the right, there are different tasks and activities related to whether you're at the preliminary stage, intermediate, advanced, and so on. So no matter where you fall into coordinated, co-located, highly integrated, there is always somewhere to move through this continuum. The other 7 domains include the evidence-based care for interventions. You see the third one here, ongoing care management. There's also self-management support, multidisciplinary teams, systematic quality improvement, linkages and community social services that improve general health and mitigate environmental risk factors. And lastly, sustainability, because as we all know, all these activities, if you aren't sustaining them, then they are not going to be helpful to you. So looking through this first domain, we can see how clinics can evolve from strictly clinical case finding approach to identifying patients to a population health focused level of systematic case finding. It's in this preliminary stage, patients with general health conditions are identified only when they present with symptoms. They are then referred to an external PCP. And a clinic that wants to make progress toward greater integration might begin by implementing a systematic approach to screening that focuses on universal screenings that is performed in behavioral health clinics. So a good example for this would be if a patient has obesity and is an active smoker. The clinic is expected to provide education and motivational interviewing to assist the patient to address these risks. Advancing to the next element would mean patients with risk factors and general health conditions are also being tracked and followed to ensure follow-up monitoring and care. Next slide, please. So this leads us into looking at the integrated care framework. So according to the Collaborative Family Healthcare Association, this integrated care is described as efforts to provide healthcare services that bring together all of the components that make humans healthy. And given that the promotion of health involves a variety of factors, psychological, biological, social, communal, economics, and so on, integrated care can and should look different based on the setting of the healthcare delivery and the participants. So this is back when we're talking about who are your peers, how are you looking at integrated care within your settings. Integrated care results in professionals working from a united framework, often side by side, whether physically or through technology, incorporating the whole patient experience, right? The patient, their family, community as equal partners. So this results should be care that is efficient, cost-effective, and resulting in positive health outcomes, as well as being meaningful and fulfilling to the workers in the healthcare delivery system, an important piece that sometimes is often overlooked. Next slide, please. So I want to start off by looking at the collaborative care model. Aims, impact, are a couple examples of these. The overview for this is that they're focused on specific populations, typically for patients experiencing anxiety and depression. These are model elements where there's a registry-based system to track coordinated care. There's a care manager who delivers brief interventions, such as cognitive behavioral therapy or CBT, behavioral activation or BA, which is an approach that combats depression by harnessing your body's responses into an active, productive schedule and so on, as mood is affected powerfully by our actions, but our actions are also influenced by our mood. Problem-solving therapy, PST, some of the other interventions. Psychiatric oversight of the care manager and PCP occurs during these models. Treat to target with standardized outcome tools. And this model is acknowledged by both the CMS and APA. The goal here is to enhance treatment and management of patients with behavioral health diagnoses. We want to do that efficiently and with frequent touch points. Next slide. So looking at our collaborative care model, we have some strengths and some limitations. The strengths include the vast array of evidence and research, support and recognition by state and federal government, which we mentioned before. There's light staffing requirement, so that should be a strength. But some of the limitations include capacity and scope, being limited capacity and scope. And this necessitates psychiatric involvement. having the psychiatrist be working with the primary care provider and the caseworker. This requires also active measurement and data utilization, because you are using active measurement and data utilization to track the progress of the patients within the program. So this collaborative care model seeks to impact clinical outcomes of patients who present with depression in primary care. And in this model, the consulting psychiatrist and care manager are added to that care team to manage the registry list of patients who meet the criteria for this program and who have, by the practice, been screened as of needing support for depression. And typically you're doing this using your PHQ-9 depression screening tool. And this is where that consulting psychiatrist provides support primarily to the medical providers to ensure that they're providing evidence-based prescribing of antidepressant medications, but they may also see patients for a short course of treatment as needed. And the care manager may meet briefly with patients in person or by phone for behavioral interventions, and keeps track of their care using a registry to make sure that the patients are improving in a timely fashion. So the key to this model is that the tracking of outcomes through the repeated use of the PHQ-9 screening tool. More recently, this model has been piloted for use beyond depression to include other chronic conditions that can co-occur with depression, such as cardiac conditions and diabetes. Next slide, please. All right, so I want to talk a little bit about the AIMS collaboration on behavioral health integration resource. So they have this new behavioral health integration tool called GROW. And basically, the tool that I'm going to talk about, it can support the full spectrum of organizations engaged in the work with patients, from those that are just starting down the path of integrating behavioral health care to those that have mature systems in place, which is really great. The Behavioral Health Integration Implementation Guide here, this GROW project shows clear guidelines on and concrete strategies on behavioral health integration, including creating the vision, building integrated care teams, monitoring progress, and providing population level accountability, particularly important for organizations that are implementing the collaborative care model. Right, so as you can see from this screen, you start here on the left. And when you're doing goal setting, you move through your resource assessment to the options, to the workflow development. And then you have some questions on the right. You assess, did we reach our goals, because you're tracking using data? And if you say yes, then you continue with your plan. If you say no, then you reconsider your approach and go back to start. So this guide includes an innovative GROW pathway planning worksheet. And this guides an organization through the steps needed to successfully integrate behavioral health care into their clinical process. It also includes a section devoted to an important topic about how to sustain behavioral health care efforts over time, because I think you start to put things into place, and if you don't think about how you're going to sustain these activities, they won't be sustainable. They won't stay long-term. Next slide, please. So I'd like to talk a little bit about primary care behavioral health, the PCB-H model. And for this model, we'll go over a little bit of the overview for this. It's team-based primary care approach to managing behavioral health condition that adds a behavioral health consultant or a BHC to the team. This BHC person is a generalist, typically incorporating elements of health promotion and behavioral medicine. It's brief, solution focused, so typically 4 visits. Population-wide focus, right? So this is the primary care physicians population. With the behavioral health consultants population, it's the same. You want to have frequent consultation to the PCP and to the nursing team. And there's a high emphasis on open access. So the goal here is to enhance the primary care team's ability to manage and treat conditions with resulting improvements in primary care for the entire population, right? So this model of care, it seeks to optimize access to behavioral health support within the primary care environment across all possible patients presented there. And in this model, the behavioral health professionals They work alongside the medical providers in real time. They're often called into the exam rooms to work with patients in what's called like these warm handoffs, where the patient sees the physician first and then sees the behavioral health consultant. On follow-up visits, the patient may see both providers or only one of the pair, depending on the situation and need. And the behavioral health consultant can provide support for mental health and concerns such as depression, anxiety, ADHD, as well as physical health concerns such as management of diabetes, hypertension, or sleep issues. Next slide, please. So we looked a little bit here at the advantages, right? Much evidence supporting successful implementation and outcomes and provider satisfaction. It is recognized by CMS. It does decrease clients' management load on PCPs without splitting up the patient. It significantly increases access to behavioral health services. The disadvantages include that there's a lack of built-in emphasis on follow-up tracking. It's not as widely recognized as the collaborative care model. It requires this behavioral health consultant to function in a way unfamiliar to many traditional mental health providers. And this is more prone to the same day billing issues depending on the provider level. So you have to look into your billing related issues, and open access scheduling management can be a challenge to manage. Next slide. And as we all know, no one type of model or circumstance fits everyone. So we're looking at blended and situational approaches. So this is directional, right? We have behavioral health that's in physical health settings, ED, urgent care, specialty oncology, and so on. And then physical health that's being provided within a behavioral health setting. So this combined collaborative care model plus the PCM-H model oftentimes works well. Contracting, co-locating, the acquisition of a different service, whether it be behavioral health or primary care, into a single entity. And looking at the whole health practice of the patient. This is where we incorporate different perspectives on achieving integrated care. So we'll discuss two, but there are many that we saw on that earlier framework slide with the tree and the leaves. So the first one I'm going to talk about briefly is patient-centered medical home movement, PCM-H. And this is an effort to improve the efficiency and outcomes of primary care clinics by promoting team-based care. This is key to the improvement in the coordination of team members, especially in the provision of care for chronic conditions such as diabetes and depression. For this reason, the organization's achieve a certification involves efforts to screen patients with key conditions and track outcomes and utilize electronic health records for documentation and communication, and work proactively with specialty providers. So PCM-H efforts often coincide with clinic-wide efforts to integrate mental health services because of the significant overlap with the quality improvement processes and goals of patient-centered medical home and integrated care. And the second one that I wanted to mention was the research behind adverse childhood experiences, or ACEs. So, and the efforts to promote trauma-informed care are central perspectives when driving the need for integrated care, given how closely tied medical conditions are with traumatic experiences. Integrated care efforts often include screening for trauma in medical settings and efforts to provide increased access to behavioral health support in the medical setting to increase patient engagement with care. Next slide. So I briefly want to just review integrated care in practice. So I wanted to ask you all, think about what you are doing and how does it look different from someone else. So as we can see here, these are different activities that many organizations utilize in practice of integrated care. So let's celebrate the ways that you're already meeting your patients' needs better, your clients' needs better due to your integrated practice, even if you don't call it integration. Behavioral health and primary care providers are working side by side along other disciplines, social work, nutrition, pharmacy, and so on. Shared health records and care plans, all providers and members of the care management team have access to and can document the patient's care in a single medical record. Universal screenings for common needs like depression, anxiety, substance use, and of use of a registry to monitor population needs. Looking over here on the lower left, providers accessible for both curbside and in-exam room consults, same-day visits, right? This is a 15 to 30-minute consult, and prevention, education, and guidance. And then lastly, same day and warm handoff availability to reduce no-shows and ensure connection to care. Next slide, please. I want to end with 2 slides. The first one here is clinical considerations. Think about, do physical and behavioral health staff collaborate on chronic disease management, like for diabetes or recovery, hypertension, depression, and so on? And what are the common conditions? Maybe insomnia, sleep apnea, chronic pain that might be evident. Cognitive concerns, attentional and behavioral issues within children. Do physical and behavioral health staff contribute to shared outcomes and measures? Are clinicians familiar with effective brief interventions and screenings? Do we even know what these are, what they look like? Are they available within your practice? And are there times where a behavioral health provider might see patients instead of the primary care provider as a means to improve access? Things to consider. Next slide. So as we reviewed clinical, now we're going to talk a little bit more about the operational, because they sort of go hand in hand. What pathways already exist or need to be developed? Think about, what do existing population health data indicate at your practice? What is most needed? How is data currently being operationalized? What staffing is available or who can be converted with support? Certain staff are primed for integrated care. Look at your team. Who would be appropriate for this kind of conversion to support behavioral health in an integrated manner? Is there efficient passage between service lines, right? This is those handoffs. This could be the warm handoff in person or a virtual handoff, the same day or open access to getting patients in to be seen by both mental health and primary care. Minimal barriers to initial touch point. Do you have those? And lastly, is your infrastructure conducive to integration? What your environment is like, what your staffing is like, all of these things play a role. Many organizations call them different things, but this was an opportunity for us to share a little bit to set the level here about what we look at when we're thinking about integrated care. And last slide for me. And here are some of the tools and resources related to the GROW guidelines and the 8 domains, and some information on integrated care for you to have after this. Next slide, please. Great. And quality improvement, Deb. You're on mute.
But of course, and that's quality improvement, because I tried it again off mute. So the second time was a breeze. So I'm here to talk a little bit about quality improvement. Again, with the very brief time with you guys, I'm not going to go too far into it, but we're going to sort of talk about the key pieces of QI and how QI looks in an integrated care delivery model, some barriers, and possibly my 2 cents on possible solutions or best practices. Next slide. So what is quality improvement? I think in the poll, the majority of you folks sort of felt that you had a moderate understanding of QI. So I just demonstrated an example of QI, making a second attempt to talk with the speaker on. That is what quality improvement is. It consists of systematic and continuous actions that lead to measurable improvement. So I had a 100% improvement the second time I attempted to speak to the group. Next slide. Some history on QI for those of you who weren't around in the early 80s. I'm going to give you some idea of what the world looked like in healthcare. It was strange. It was a different world back then, as my colleagues would say. There wasn't a whole lot of QI structure in the way that we see it right now. Like, everything is monitored and measured in a way as best as we can. But back then, it really didn't exist the way it does now. In fact, the idea of quality improvement was so unique. It was regarded as almost like sacrilegious in the healthcare arena. And that's because, we had a reputation. The United States system, the healthcare system, had a reputation to being the best in the world. And we were curing disease and, having miraculous outcomes when it comes to infectious disease and chronic disease. And people's lives were changed in terms of longevity, living with conditions. So things were a bit different. And the way we looked at it, and the question of whether or not should we question how healthcare is delivered, that really wasn't a question. Like, how dare you question it? So for the most part, the history of medicine looked very different. And I can't even imagine sort of being where we were then and being here now and us looking at the way we quantify stuff. But yeah, it looked very different. And the behavioral health industry, unfortunately, I wouldn't say there was a huge leaps and bounds, but certainly there had been some differences. It was unfortunately ignored for the large part due to like stigma. And I don't know another way to sort of say it. It is what it is, but we did not look at behavioral health, clinical quality, or behavioral health quality the way we looked at physical health quality. In fact, those two sort of like didn't sort of intermingle with one another in a way that, at least the way I was trained. Next slide. So to continue some history, this really cool guy on the left, Don Berwick, who most of you may know is like the king of IHI. He heads up Institute of Healthcare Improvement. He had did some work way back in the 80s, and he did a national demonstration project, which was sort of like our precursor of quality improvement and quality improvement program that we see here now. And what Don Berwick did was he got a bunch of his friends together, and that team studied what other industries were doing in quality improvement. And that attracted him to some of the work that this gentleman here in the middle, Deming, was doing. And Deming, not a physician, not a clinician, was a statistician. He was an ishin, but not a physician. And he had did some work in Japan, and he had revolutionized how they sort of looked at quality. And Japanese cars, if some of you may not know this, they were sort of built to sort of withstand. And they took a lot of pride in the work they did in building a product that would withstand the test of time. Deming was sort of like the grandfather of how we quantify or look at the way we measure quality. And then the other guy that sort of stepped in that Don Berwick's team had looked at was this gentleman named Don Abadian. And some of you who are old school might remember his sort of Don Abadian triad, which is looking at delivery systems in forms of structure, process, and outcome. And he had adopted his 7 pillars of healthcare quality. And he connected how systems, right? The system is only going to produce what the system produce if it was set up to produce that. So the structure had everything to do with how the processes were put into that structure, and the outcomes were only going to be what within that system had produced. So it was really interesting, some of the stuff that Don Berwick's team had put together. Next slide. And I think sort of the pieces that sort of all sort of come together when Don Berwick did his work was to understand and to know that you need measurement. There is a critical role of measurement. And as you can imagine, in the 80s, we did not have EHRs. We wrote everything in charts. We just did not have the systems and the mechanisms in place to do what we do right now. So you can imagine, like, how would a patient know that they got good healthcare? The only way to know that is that we would measure that. How would a provider know that they got it right, that they did something that improved or improved the patient's outcome? The only way to do that is to measure it. And how do insurance companies know that, you know, and employers, and in fact, insurance companies and employers, how would they know that they are paying for the best care, the best science, the best skill, the best compassion? They measure that. It's the only way for us to understand it. And certainly I was there when all this stuff was happening on the cusp of it. And I know that measurement has been a battle between healthcare delivery and the healthcare measurers. It has been a battle. It still is a battle, but now the voices of those such as yours are out there speaking up and responding to how we look at measurement. Next slide. So some continued conversation on some of the critical role of measurement. We were looking at applying some industrial QI methods back in the 80s and 90s. Why? Because it really wasn't anything else to reference. So measurement in healthcare quality was really sort of based on how other industries were doing it. And then eventually we were starting to figure out things on our own, and we get to the present point, which I'm going to talk about shortly. So way back then, when we sort of did some initial sort of attempts at measurement, there was a report that was published, and all of you may have known or heard about this, which is called To Err is Human. And that report, it was sort of like the first time we were putting a spotlight on our healthcare system. And we talked about, in that report, I didn't talk about it, but the report basically that was published by the Institute of Medicine said, people are dying. People are dying in the hospital systems because that's all he could measure against, right? We weren't looking at provider care in small FQA, well, we didn't have FQACs at this time, but we weren't looking at provider care delivered at small primary care independent settings. We're looking at systems such as hospitals. And they said that there was between 44,000 and 98,000. It's almost it's more than a 40,000 point or people difference in that one, that we couldn't even get that number tight enough to quantify it. But between 44,000 and 98,000 deaths annually due to quality deficiencies in our systems. That's a lot of people. And then also there's a wide gap in that because we couldn't even measure that right. But to the best attempt, they put that report out. And we did a lot of work in our industry to sort of address the fact that we've had a lot of issues in our hospitals and looking at avoidable deaths, right? Fast forward, we had the National Committee of Quality Assurance, NCQA, which is the HEDIS gods. They produced the healthcare effectiveness data and information set. So that was sort of like our start. In the 90s, we started to really sort of put some structure in place to understand how we can measure and quantify healthcare delivery, healthcare outcomes. But again, we were still in the paper world for the most part. And just to give you some context, a lot of our healthcare providers still to this day do not use electronic medical records. So again, 91, 2001, 2021, we're still in some environments, still in a place where we cannot pull that data out to understand how that provider perform, how their patients are resulting in their healthcare services. So to go back to 2001, we had yet another report. So the IOM did this thing in 91. They came back again in 2001. This one was a little bit more towards what we're looking at today. And that report was Crossing the Quality Chasm. And basically that report said that it was not a gap, but a chasm of expectations between what we do in healthcare and the actual performance in healthcare. And then we started looking at ourselves against other countries and so on and so on. And in fact, although the US healthcare system, I think, is unique and excellent, we still spend a lot of money and don't have the same outcomes that other countries have that deliver sort of parity-like care as we do. Current industry tools, fast forward to today. Measurement, again, is a critical piece. There's a lot of measuring sticks. And I know that that's like the #1 issue that I've found when I'm working within the healthcare system and then also trying to support providers such as you to sort of respond to those who are asking for data. So the measuring sticks, the industry tools that are used that are common, which are things such as CCHIT. So CCHIT is a certification commission on health information technology. I mention them only because when the adoption of EHRs became very prevalent, we did not have a mechanism to say, well, Dad, are the EHRs all collecting information and spitting out that information in the same way? And what the government did was, okay, we need like a mechanism to say, we need to create a structure. We need to create a shared language so that all EHRs, if they're sort of meeting these standards, at least those who are using it or interfacing with it, like our providers and our healthcare systems, they're going to be able to draw out the information that they need and perhaps in the future be able to report that out in a way that is seamless. So to me, the very first sort of measuring stick was, are you using a system that is allowing you to now procure that information and that data in a way that is going to allow you to submit or share that information with those who are asking for that data? So to me, CCHIT was sort of like the onboarding of technology and making technology responsive to what we need in our healthcare system. UDS is another sort of metric that is used, or a mechanism to allow us to understand how our federally qualified health centers are doing on an annual basis. It's not perfect. By no means it's not perfect, but at least it's a snapshot in time that allows for HRSA to understand how our FQHCs are performing in certain indicators. UDS also includes things such as number of patients being seen, the circumstance of those patients. So social determinants of health understanding is in there before it was termed social determinants of health. So we appreciate UDS as having that information available. Another metric, another sort of common measurement tool that the industry uses is patient experience. And my colleague Maya would tell you that certainly when you look at our industry, you think about a patient's experience and how that patient feels about that provider, that exposure, that walk through, that visit that day. Unfortunately, there is definitely some intersection between a patient's experience and the outcomes for that patient. And patients who like their providers, feel engaged by their providers, and even if the provider doesn't have great bedside manner, but has the ability to influence, to get patients to perhaps modify or change their behavior. We see that those experiences, good experiences, now also relate to good outcomes. And then for your behavioral health, we talked about all this technology in the physical health. We look at behavioral health, we're still looking at doing lots of chart reviews. That's amazing to me that we still haven't moved the industry in the behavioral health arena in a way to quantify what we do the way we do it. And when I say chart reviews, I'm talking about looking within the clinical condition and not whether or not, are we looking at loss to care numbers? Are we looking at number of patients engaged? Yeah, you can collect that in any sort of practice management system, but we're looking at within the condition, within the behavioral health and mental health condition, how are those patients performing? How are they resulting in? What are the outcomes? You can do that for diabetes. You have a set of metrics that says this patient has diabetes, and these are 4 or 5 different indicators that tells us whether or not that patient is progressing or improving in their care. We don't have the same robustness in the behavioral health arena. So that's why we know we can't give up this fight when looking at the critical role of measurement. Next slide. So I wanted to sort of pull back and talk a little about behavioral health, quality improvement, quality assurance, because again, it was sort of ignored. So all that history I talked about, I wasn't talking about behavioral health for the most respects. Now I am. So during the 80s and 90s, we really wasn't doing quality improvement per se, the way we think about it in the physical health world. We were looking more at quality assurance, and we had a lot of behavioral health providers that attempted to do things like they were using something called statistical process control or SPC. Some of them were using other models of looking at systems and process. One was called the total quality management tool. And when I did some research on this, I found that pretty much no one thinks that these methods or these tools sort of worked. In fact, they felt that both methods sort of failed to make any transformative impact in the way behavioral health services are quantified. Why did they fail? I can imagine maybe because we didn't have the skill set of the individuals doing the work to be able to, utilize these tools. And then also there's a huge focus in the behavioral health arena on documentation. Documentation really is how you're able to now incorporate that patient's circumstance when they hit your door, what you've given to them in terms of guidance, and then what your suggested or plan of care would be. Obviously, there's a barrier when you're thinking about everything being written up in the chart. And as you know, in the physical health world, everything is being written up in a chart, but what's going in with that are codes. And those codes are sort of like that make or break of whether or not we can then quantify status of patients and timeliness of like, is their issue now solved for? We're doing some of that work now in the behavioral health. Me, Amy, and Maya are working with organizations here in New York on looking at how to quantify even more, like adopting real sort of QI structure, looking at doing sort of in-depth PDSSAs, and then more importantly, documenting how we're collecting data. So we know that there's some work to do on the behavioral health side. Next slide. So this is where I figured I'm gonna give you a little visual because Amy had a lot of visuals. So I wanted to give you a little visual on, the hot messness of metrics and measures. And so what I did was I went to National Quality Forum. So the National Quality Forum is basically a mechanism that sort of says a lot of folks have suggested that this particular metric is a good idea. And then what they do is they submit their metric to NQF, or the National Quality Forum, and then their reviewers sort of like go through it and they put some love on it and make some suggestions, and then they vote on whether or not that metric should be endorsed. And that's how we got to a lot of the metrics that our physical health side is using. So Endorsed measures mean that measure can now get into systems to be measured even more. When you don't have an endorsed measure, as you can imagine, when you're saying, oh, I have a good idea, whose idea is it? It's my idea. Will the federal government endorse something that was my idea? Not with a lot of scrutiny. So what happens is an NQF measure that's endorsed, it now opens the opportunity for that measure to be, in EHR companies, for example, to say, oh yeah, we'll incorporate that in our measure specifications capabilities when our EHR, when you're looking at health plans, for example. Oh, okay, if you think that's a good indicator that you're doing a good job with that schizophrenic patient, then perhaps we'll incorporate that in our quality or value-based payment initiatives when we're looking at behavioral health services. So endorsed measures means everything. What this visual is showing you is on the physical health side on the left, my little blue bubble, those are some of the measure stewards. So Centers for Medicare and Medicaid, HEDIS, which is NCQA's Healthcare Effectiveness Data and Information Set. I can't say that twice fast. NQF not only is sort of like the measure sort of holder and reviewer, but also they also recommend measures as well, or metrics as well, to be endorsed. The AMA and the Joint Commission. I'm just giving you a few. It's not an exhaustive list. You'll also see a subset in my bubble, EHR reporting capabilities. And I want to sort of emphasize that that is your make or break when you're thinking about integrated quality improvement in a behavioral health / physical health setting. In an integrated setting, that EHR makes or breaks you making your providers' lives miserable or very effective and efficient when you're giving them the opportunity to respond to data that you procure. On the right-hand side, I pulled together who are the measure stewards on the behavioral health, mental health, and substance use disorder side. So as you see here on the right-hand side, I don't have that red bubble touching that thing on the right-hand side. You notice that? And I'd love for you to chat, because if you got a red bubble in your systems that's pulling all that data, that looks at not only quality on outcomes, perhaps on, is the patient getting more than 30 days of visits, but looking at within the condition, I would love to hear you chat. So again, we see these mechanisms exist. We're at least moving forward and making sure that mechanisms exist for measure stewards and measure specifications to be put together for the behavioral health, mental health, and substance use side. But on the physical health side, we are light years ahead of the industry, of the behavioral health industry. And when we're talking about getting together and working together, we need to make sure that there's parity in that quality improvement agenda. Next slide. So to sort of drive it down even more, because I like to sort of make the point 3 different times, just to make sure you remember it. I looked at a report that was done on what the heck is happening with behavioral health and quality improvement. So as I mentioned, a National Equality Forum is sort of like the holy grail. They hold on to all the measures, and even you guys, you might have someone on the call who's actually submitted a measure specification to NQF. When you look at the measures that they have looked at, they had 510 measures, for examples, that they looked at. And I think this report from 2015. Nearly a third of those measures address broad mental health or substance use conditions rather than specific conditions, right? It is like they're looking at, did they finish treatment? Like they're not looking at in the condition. 72% of process measures. Just, did you do X? Did you do Y? Did you do Z, right? Most common data source for these measures is administrative claims. It is 2015. We have already had a decade in 2015 of EHR adoption, well over a decade in, and they're still looking at administrative claims. Y'all know what that means, right? Paid claims data, right? Very few measures rely on EHR. I didn't make it up. They're saying it. Very few measures relied on EHR, right? So that's a problem. 2015, it was a problem. I don't think a whole lot has changed since then. Now, looking at more information in this area, 53 measures, or 10% of those measures, were endorsed by NQF. That's it. Only 10%, 510, and only 10% were endorsed by NQF. So what are we doing, right? What are we doing in making sure that we are identifying good measures? Because obviously for so many to be endorsed, something was wrong with them. There was some feedback that was given perhaps by NQF, but we have a problem. So several subdomains of the National Behavioral Health Quality Forum, such as treatment, intensification, financial barriers to care, continuity of care, lack of measures that NQF endorsed. That is what they endorse. So again, it's not within the clinical condition. It is sort of looking at sort of like the outskirts, right, of those conditions. And perhaps in some instances, like financial barriers to care, it is looking at perhaps a social determinant of health sort of pre-indicator, whether or not that patient's care is going to be continuous. Next slide. So I say all that to say, the struggle is real. You want to do integrated care, we love it. We love to see integrated care because to me, that's regular comprehensive care, but the struggle is real in the QI arena. And when we think about QI integrated care, we have to wonder, is it a difference in size when you see the outcomes in QI? Because certainly in small practice settings, QI is a struggle. We're not even talking about small practices that are integrated. We're talking about small practice period. QI is still a struggle for some providers, and QI programs are duplicative. It's confusing. It's frustrating. When do I have to report? How often do I have to report? From what period to what period do I have to report on? There's extensive lists, QI measures for physical health, but there's a truncated list of QI measures on behavioral health. And if you have an integrated program, don't you want all providers to feel as if what they do and how they do it is being quantified and feedback can be offered so they can circle back on that? Technology utilization widens the barrier gap. We just don't use technology in the same way in the behavioral health settings that we see that are emerging the way we have been using in the physical health settings. Next slide. So my 2 cents on what it would look like to be successful in the integrated care setting for QI, and certainly some of you might already have this, but I always think about these things. The planning is everything. When you bring on board integrated care, and I don't even care if it's not even behavioral health, it could be HIV care integrated, it could be whatever integrated it is, you got to plan for it. You have to plan, what does that mean? And how do we have to now think about what we do and how we do it and how we measure it? Executive engagement is paramount because really sort of like the charge comes from the top. So executive engagement is really critical and making sure that those who need the authority to do this work can do this work. And then more importantly, that executive engagement then puts in place informed and engaged staff. The #1 reason why we failed at getting behavioral health to the place that we are in the physical health world, besides stigma, let's not forget about that. I'm going to talk about it a bit in the DEI component. It is because we just didn't have the same skill sets in that arena to allow us to be able to get that data procured in a way that we have more now. And then QI culture. Let me just say this on QI culture is either you got a culture of QI or you don't. Some of us are still just saying, let's just run the numbers, submit the data, we'll think about it later. And that is not a culture of QI. It is, you can pull the data and you're just submitting the data. That's not a culture of QI. It means you're defeated and you're down and you're trodden and that's the last thing that you can think about right now. Technology that works for integrated care delivery is everything. You have to look at your systems and decide, do I still need to continue using this system because it ain't working for me? If I see one more workaround for someone who's decided to bring in integrated care and then the system itself, the thing that they document into, they have to do a workaround, it's insanity to me. But yet you want to be able to procure data out of that. And then finally, unbiased analysis. You want to have an integrated care system that works where the quality is valued and appreciated. You need to make sure that you look at your data in an unbiased fashion, and then you make decisions that perhaps can change or modify how our providers and our caregivers work, but more importantly, the success of our patients and our patient populations. So I'm going to transition now, next slide, to our DEI discussion. And, who knows this better than most of us in the behavioral health world, but certainly diversity, equity, inclusion is really sort of like a common theme that's being talked about right now in our healthcare systems. And certainly, is a discussion we're having at our organization as well. But I have a quick poll. Next slide. very quick poll on how comfortable are you talking about health disparities amongst your colleagues? So we're going to allow you guys just a few seconds to respond to that. Oh, thank you. So, oh, I'm clapping. Awesome. I see that at least 23% of you are extremely comfortable. And it's a very, let's look at this, not hardly any of you are not at all comfortable. But listen, this is a no judgment zone. So I appreciate you even putting in that feedback. Some of you, 8% are slightly comfortable, 34% are comfortable, and then 34% are very comfortable. But yeah, I'm going to have a quick conversation, diversity, equity, inclusion within the behavior or the integrated care setting. Next slide. I appreciate that feedback. That's super helpful. So when we talk about health equity, we talk about DEI, I think sort of, I land on health equity as sort of like a, let's just say what this is and making sure we understand. We all lived through COVID, unless you've been on a rock. We all lived through COVID, and certainly COVID has given us a simple demonstration of, well, I don't understand what you mean by, equity in healthcare, and you see the outcome or the outputs of what COVID has done. And we saw a disparate result of those who not only suffered from the disease and or the infection, but also have had mortal outcomes from the infection. So health equity means giving patients the care they need when they need it. Or as the Institute of Medicine report has put it, it says that health equity means providing care that does not vary in the quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. I want to be clear that equity is not the same as equality. And I was hoping that this little visual will help you see that that certainly there is a difference. We've had some experiences here in this country where they thought, oh yes, separate but not equal. But equity is not the same as equality. And then we're going to have this quick conversation on DEI. Next slide. So this term of equity, this term of health disparities, although the term disparities is often interpreted as a sort of like a precursor of, oh, we're going to have a race conversation or ethnic disparities, it's not only that, right? So we know that equity can happen, or the lack of equity can happen in circumstances besides it being a racial thing. You can have a community haves and a have-nots, or the right side of the tracks, the left side of the tracks. So that's a disparity, especially when healthcare outcomes are varied. So there's many dimensions of disparity that exist in the US. Health disparities adversely affects groups of people who systematically, typically got the sort of like the lower end of the stick. They experience greater obstacles in life. I've heard this term life sucks disease. Unfortunately, they've had sort of circumstances or born in circumstances that sort of put them in a place where they may not experience the same things that others may experience. So whether it be a racial divide or ethnic group, a religion, a socioeconomic status, a gender, an age, a mental health condition, cognitive capabilities, sensory, you name it, everything can end up with that individual having a different outcome than what another individual or another group might have. Disparities means there's a difference. And equity refers more to the reason behind the disparities. So just think about that for a second. Next slide. So disparities in mental health and behavioral health, we're going to talk about that, then we're going to talk about sort of the physical health world. A report on the Surgeon General states that despite the extensive effective treatments, disparities still is an issue. Access to care, quality of mental health services for racial and ethnic minorities, it's just not where it needs to be. And there are lots of reasons why. I tried to highlight a few of them for you. There's lots of reasons why. There's no sort of one set reason, and geographically, when you go across the country, one of these sort of issues might sort of align more with others. But there's things such as lack of availability, where we literally have parts of our country where there is no access to behavioral health providers. And then sometimes it is by design where that lack of access is sort of instituted. Why that is, you name it, racial issues, cultural issues, religions. There's lots of reasons why. Transportation issues, difficulty in finding childcare for someone who needs to get access to care. The belief that mental health treatment doesn't really work, right? And sometimes you just gotta pray, you gotta pray that out of them, right? Mental health systems weighted heavily towards non-minority values and cultures. To me, the community that I live in, that's what we see that's most pervasive, which is the system doesn't even understand how to address or talk to the community in which they're trying to service, and therefore that community doesn't respond. Racism, biasness, discrimination, treatment settings, right? You name it. There's a lot of issues why. So these issues, unfortunately, create this sort of differences or disparate outcomes. Next slide. Each year, people belonging to a racial and ethnic minority groups experience worse behavioral health status and treatment outcomes, along with more difficulty accessing services. Keep in mind, we really don't have the mechanisms to sort of measure within the condition. So based on what they were diagnosed with and what the outcomes were. But so the way they're measuring this, you know, think about that for a bit. But what they can do and what they're able to measure, there's still disparities between those who belong to an ethnic minority and then those who do not belong to an ethnic minority. These disparities in behavioral health care include people's mental health and emotional well-being. So what's happening now? With all these issues that we've seen in the past in terms of behavioral health and behavioral health integration, I think the payers, the legislation, I think they all are recognizing now you cannot ignore the fact that people need help. And that if you want to impact the physical health, as Amy had mentioned, you have to think about, well, why is that patient always in pain? What is going on with them? So you can't just keep prescribing them pain meds. There's got to be something else going on with the pain. And now the industry is trying to, or the payers are trying to say, okay, I think we get it now, and we're responding to it. So what's happening now has been a bit of a call to action. You see now that there's been legislation across the country that focusing on disparities on mental health and behavioral health issues. There's been some cultural competent workforce training and services that we see a whole lot more of that happening. And I remember when we were doing some cultural competency work when I worked for a federal program almost 20 years ago, but it sort of lost its flavor, and people's like, I kind of sort of know who the community I work with, but those communities changed. Those environments change, groups move out or new groups move in, and therefore the cultural competency education needs to be sustained. We also see that we're collecting better data, and that's because those of you who are in the industry are responding to and saying that we need to drive change in the policies. We're tracking things better. We're looking at more relevant data to reduce behavioral health disparities, to reduce behavioral health bad outcomes, period, but more importantly, health disparities when it comes to behavioral health. Two key areas that they're looking at is alcohol use disorder and substance use disorder and those disparate outcomes. Next slide. So in summary, again, I couldn't go into it the way I really wanted to, but certainly we can chat about it later in our office hours. DEI integrated care is a struggle. Access to services is not equal. And then you have this thing, I don't want to sort of belittle any community. That is not my my goal here, but we have to understand that sometimes culture eats everything up in terms of what makes sense, right? I don't want my practice to take on the burden of seeing mental health patients. That might be a provider's cultural understanding and thinking from a stigma perspective and thinking from a culture's perspective. My patient population doesn't want to see patients who need treatment for substance use sitting next to them in an exam room, or not in an exam room, in a waiting room. They don't want to see that. So when you think about it, it's like, oh my goodness, our providers need help. Our providers need education. Our providers need to understand that behavioral health integrated with physical health is health. That's all it is. It's just wellness. It's health. And issues such as, I don't think my patients feel comfortable. In most cases, it's the providers not feeling comfortable. Providers don't have that skill set to have those conversations with the patient. So you see lots of screening, lots of referral, but then again, we don't see the physical health providers and adopting some of these practices internally and learning some of these additional skill sets. They don't mind doing the referrals, but again, I think there's still sort of a barrier in thinking about it. And then most respects, you also see that barrier with the patients responding to that as well. Stigma is real. And it comes from providers, it comes from community, it's the unconscious bias, and sometimes the very conscious biasness of it, but stigma is real. And we need to think about what our cultural and religious influences and how those impact our integrated care delivery models. I think conversations need to be had. So when the majority of you guys mentioned that you feel comfortable about that, feel comfortable when you see something. Because I remember a long time ago when I sat in a healthcare setting, clearly seeing providers discuss a treatment plan for a patient, clearly based on the fact that they come from a certain ethnic minority and why they chose that treatment plan. I said nothing because I didn't feel comfortable speaking up. So I'm saying to those of you who feel moderately or very comfortable, speak up when you see something such as that needs to be addressed and nip that in the bud. So now I'm going to transition to my colleague, Maya, and she's going to wrap it on up for us.
Hi, everyone. So we are coming to the end of our presentation, and I know many of you have questions, so I'll go through our slides fairly quickly. So what I wanted to talk about today, just to sort of round out the presentations of Amy and Deb, is really to talk about communication and how it might be a little bit different depending on what type of integration you are working with. So Amy introduced this idea that there's really 3 different levels of integrated care: coordinated care, co-located care, and then fully integrated care. So next slide. First, we're going to talk about coordinated care. So this is really where you have care being provided at totally different locations by different providers, presumably on completely different EMRs, so there's no real integration there. And then communication between providers would be old-fashioned. It would be facilitated by phone, maybe secure email, possibly fax as well. But basically it would be something that would be very thought out. It wouldn't be a quick message through your EMR. And so it is definitely recommended that you have some sort of memorandum of understanding in place. And what we like to incorporate in our MOUs when we create them is to really think about specifying your communication expectations. How often as providers do you want to touch base, and what type of information should be shared? For example, maybe you want to actually actively share a patient care plan. That's sort of, best case scenario. Or maybe it's going to be a lighter touch and it'll just be sort of reviewing visit notes. Either way, it's a really good idea to at least include that in the MOU, so there's a general understanding of what everybody's expectations are. And then, of course, in terms of communication between providers, we actually really need to have consent from the patient. And that consent really should be received by each of the different providers. And unfortunately, that is 2 different forms, 2 different signatures, because both providers are operating at different institutions. Next slide. The next alternative is, of course, co-located care. So this is presumably 2 different provider groups, most likely, separate practices officially or legally, but located at the same facility. And this is a circumstance where you may or may not be on the same IT system. If you're technically sort of a part of the same organization, you may be on the same IT system, which would be fantastic. But it doesn't necessarily mean that you're all huddling together and sort of actively communicating about patients. Either way, that would make it much easier to send messages through the EMR. I am finding that many practices I'm working with, behavioral health practices that is, are working on their own IT system. So they have their own sort of behavioral health EMR, even though the medical practice may be using a, more primary care focused EMR. That can be very challenging. And so, what about an MOU? You know what, the thing is, sometimes you do need an MOU, even though you're in the same physical location. That is definitely something that you should err on the side of most conservative. It is always good to have in place, unless you're sort of operating and employed by the same organization. You probably do need some sort of MOU in place. It is generally true, though, that there are going to be fewer access barriers. And just by the nature of being in the same facility, you actually do have that option of having, huddles if you wanted with around individual patient care, and possibly sharing care plans. In terms of consent, we actually still recommend that you have the patient sign consent under each provider. It's just good to do. You can consult with your legal experts about whether or not it's necessary. But again, this is an area where we always say to sort of defer to the most conservative interpretation. Next slide. And of course, the last option is fully integrated care. So the assumption is that you most likely are on the same system. And in terms of the coordination of care, you don't need an MOU in place. You probably can have huddles and really fully integrated warm handoffs, so that there really is a nice communication between providers and patients as well. This is, of course, the gold standard. This is what we're all hoping to have. And it really can be wonderful for patients, best facilitated by a shared IT system, though, as I mentioned, it isn't always the case. For consent, it is still a good idea to have patient sign consent. This is really just, again, the most conservative approach. You wouldn't need them to sign it twice. It would really be just sort of consenting to have your patients, your providers communicate, but it is always good to have consent in place. Next slide. So there are many PHI challenges to integration, which of course is what I was hinting at through all of that and sort of finally getting through to here. I think integrated care requires healthcare data sharing, and we've come a long way with this, but I still think we can all agree there's a long way to go. And the current limitations on data sharing are there's many movements to just move towards greater interoperability. And we're noticing that on certainly the local level, the state level, and there is a push to have it more on a national level, though we have a long way to go to get there. I think having more data sharing is very obvious in what it leads to. It definitely, we have reduced medication errors, we have a decrease in duplicate testing. It really allows for more multidisciplinary input in care plans, which is something that I think a lot about. We do a lot of work related to patient-centered medical home. And in order to do a really robust care plan, you really do need input from all the different providers that a patient is receiving care from. And of course, it does facilitate more robust population health management, so we can really get an idea of all the indicators that are affecting our population as a whole. Next slide. So really, what we really want to encourage is communication with patients and making sure that they understand the need for consent. And I know it's sort of an annoying, frustrating conversation, but I think the truth is, patients don't always understand that their data is not already being shared among providers, that even, particularly in a co-located environment, just because you're showing up at the same building doesn't necessarily mean that the providers you're seeing have access to your data. So I do think that there is a need to really nicely communicate this to patients in a way that makes them realize that this is all for their benefit. It isn't like, their information is going to be shared out on social media. It is for their health and their well-being that we are sharing this information. So this is sort of a push from me and from PCDC to really train our staff members, and I'm not just talking provider staff, I'm talking all levels of staff, and especially some of our front desk staff, to be able to communicate this need for consent, because honestly, it's coming from them most of the time. Most of the time, all those forms, all the signatures are being performed at front registration. So really, like, teaching everybody on motivational interviewing techniques, plain language, or giving them a script that is, extremely health literate and actually answers some questions in case they are asked them by the patients. These are really, really good ideas that can significantly impact your consent rate. Next slide. So that really brings us to the end of today's presentation. We really hope that we've given you some successful ideas for success in integrated healthcare that you can bring back to your organization. Deb provided us a great history on integrated healthcare and quality improvement, and then a little tidbit on how diversity, equity, and inclusion can help build a more informed integrated delivery system. So thank you all. We will open up to questions now, and we also have an office hour after. Oh, and we have one more poll, I apologize. So please go ahead and rate your skills and comfort with applying quality improvement techniques and approaches to inform your practice of integrated health.
Great. So thank you, Maya. Thank you, Deborah, and thank you, Amy. So we have some time we've had a lot of actually, and Jaime, if you'll, or can we advance us to the last slide? So we have some time for additional questions and also comments. Folks have been very generous in the chat, and it's been fun on the side here, I will admit, in terms of sharing some of your experiences. And we've been answering some of the questions from earlier in the discussion on one-offs. But definitely, I think these, let's just, we've still got folks, just run one more slide down. There's a number of upcoming events I do want to highlight from the Center of Excellence. So there's webinars on all sorts of other topics, including substance use, there's a deeper dive on equity and inclusion. Rural health has been a huge topic, and I've seen some of that come up in the chat here. And if you'll go, one more slide over, I do want to just make sure that our contact information is up here for folks as we do the Q&A. So you can reach us broadly at cqp@pcdc.org. Again, I've been schooling you on our website, pcdc.org, to follow this series, pcdc.org/integration. But you could check us out more broadly. There has been a lot of discussion, especially in this past 45 minutes or so, Deb, Amy, and Maya, on EHRs and the many questions and sort of communication methods. Any just general thoughts about that? I mean, I think one of the suggestions was to have a whole session on that. Any other tips you could share in terms of navigating different EMRs or EHRs, getting them to sort of speak to each other? Maya, you were sort of talking about that in terms of some of the IT considerations. There's a lot of interest there.
Ask your EMR vendors before adopting the capabilities to interface with other products you may have, or you might just
and the cost.
Or just consider starting anew. Once you've gone through your integrated model and you feel comfortable that you've gotten a good you got your legs underneath you when it comes to that, then you can start looking more strategically at a product that's going to benefit all of your providers and not just some of your providers.
Yeah, I think that's a great point. We don't, at PCDC, we don't have like a vendor we necessarily recommend, but it's interesting. Even in other conversations around integrated care we were having, even just earlier today, it sort of comes up, right? The EMR that you use in many ways can be a guiding influence or force in terms of, well, what kind of reporting can you really engage in? How do you sort of measure quality? How do you sort of, the EMR in many ways sort of dictates the behavior of us as clinicians, right? And so these are really important considerations. Let's see, there was questions in the chat about open access scheduling. This comes up a lot. And I wonder even about, I think about this from like a QI lens too. Maya, I see you nodding your head. Any thoughts on that?
Open access scheduling, I feel like the whole country rather, has gone back on and forth on ever since its inception. And I really think it has a place still, it really does. And in certain environments, it really, really works well. I think these days, I very rarely see it fully implemented, which means, like a solid 30% of your appointments would be available for same day. And you would only be booking out appointments, 2, 3, maybe 4 days, but not further. Truthfully, it's fairly rare that I actually see that. I think it's great though. And I think in certain populations with certain type of service, it can work way better than booking appointments out, for 3 or 4 weeks, for months for that matter, so I definitely think there's a great place for it, and really no better than integrated care. In fact, Amy and I have been working on a project now for a little over a year with a behavioral health practice that actually wanted to implement in open access scheduling. And, we've sort of, it's been an interesting journey. We've done a lot of quality improvement cycles around it. And I think we have come to a good place where we have basically significantly increased the availability of like same day type appointments and a whole triage mechanism. And it's very interesting, but we ultimately didn't do full open access scheduling.
I wonder if there's a lot of interest in this, maybe, and I know there's it's so much to get into in our just couple of minutes here, but what kinds of, from when you're doing a quality improvement initiative around around open access scheduling, or really anything about scheduling, right? Whether it's same day availability combined with scheduled, what might be some what kinds of things should folks look for or examine when they're doing, let's say we're doing like a PDSA or something around scheduling? What are the considerations that we might want to think about?
I mean, to build on what Maya was talking about, we did, the organization that we're working with, they came up with a survey to survey their clinicians, because the real concern was, what's the perception of the clinicians and how are they feeling that they're doing as far as the obligations for their work and the obligations to their the clients, and getting a better understanding about where the clinicians are at in not just the visit itself, but the documentation of the notes and the whole cycle of the visit, I think is something that we were able, with the time we spent with this organization, to improve upon, because we're looking at both the clinicians, experience as well as the patient experience.
I love that Amy, that you brought that up. I mean, that, right, where, I would sort of, the first things that came to mind were, okay, what's the actual availability in the schedule? What's the sort of, are there no-show rates that are being impacted? But yeah, I mean, the actual provider experience is such a huge element whenever we're sort of changing up the flow of the clinic or appointment times. When I've worked in integrated environments, the flip from 90-minute intakes to sort of brief, 30-minute visit types, that's a huge shift for a lot of us who maybe weren't trained this way or didn't kind of come up through an integrated care system. And when we're in the midst of really a workforce crisis, that has to be part of the equation. So I'm so glad that you mentioned that. Let's see, we've got just a couple minutes left. I'm just scanning the questions. There's so much here. Let's see. Deb, can you talk a little bit about billing as incident to? Is there when it comes to integrated care, there's, I think it's probably state by state, right? We've got FQHCs, we've got, I'm a LCSW, can I bill independently? Can I bill incident to? Any sort of general tips? Because I know it's a lot of this is state by state and sort of provider by provider. If we're trying to navigate that, where should we go even?
And so Maya and Amy are our certified billers and coders. Incident 2 is that seeing a patient the same day for a physical health visit as well as a behavioral health visit?
Yeah, I think so. Or if you're like if you're a social worker perhaps and you're not in your state, like you can't be independently licensed, or you sort of, do you have to bill incident two to see someone?
Yeah, so I think we're making a lot of headway, especially if we're thinking about integrated care. And as Medicare has given sort of provisions to allow for that sort of handoff or that same day service, and that both providers can do what they need to do to get the patients, and no one gets sort of turned down in terms of payment, which is, I think, is I'm not even sure what was the idea behind that in the first place, besides being restrictive in terms of care delivery, and saving someone money, but certainly not saving the patients a better outcome. But it does go by state, and certainly you can go directly to health plans and inquire and ask those questions about an individual patient plan to see what their provisions are when it comes to that. So definitely do that.
All right. Well, so I think we're just at the end of our half hour here. So today has been a whirlwind of information, but if you've been to our discussions on integrated care before, this is what you get. So it's a lot of information, a lot to digest. That's why we're making the recordings available to everybody who's attended today. They'll also be posted to our website next week, so you can share them with your colleagues, anyone else. These are free resources that are open and accessible. Thank you, and thanks to the support of SAMHSA and the Center of Excellence. It looks like folks are having to drop off, so I'm going to wrap us up here. Deborah, Amy, Maya, thank you so much for your expertise and for taking us through today. Folks are going to get a survey that will come up. We'd encourage you to share what other topics matter to you. What do you want to hear about next? Our next session will be in February. We'll be talking about partnerships, but also, of course, many other things. Would you like deep dives on other topics? What matters to you? And of course, I also just want to thank Chaim, Kimmy, Kristen, and many other members in the background who support this great work and today's production, and the hundreds and hundreds of folks who joined us today. Thank you. Enjoy your weekend, and we will see you in February.
Thank you, everyone.